questioning processes, we now move to something even more fundamental, that's trust. In today's healthcare environment, trust is no longer just assumed. It has to be earned consistently, transparently, and sometimes under scrutiny.
This session explores a powerful question. What do patients really expect from hospital governance today? And perhaps, more importantly, are we meeting those expectations or defining them ourselves?
We are honored to have Mr. Som Mittal, Chairman, Patients for Patient Safety Foundation, as a chairperson for this session, bringing a unique perspective on patient safety and accountability.
We would also like to welcome our panelists, Dr. Carsten Engel, Chief Executive Officer, ISQua, Dr. Sodzi-Tettey, CEO, National Vaccine Institute, Ghana, Board Member of ISQua, Dr. Atul Kapoor, Founder and MD, Regency Healthcare Limited, and Dr. Elom Otchi, Technical Director, African Institute for Healthcare Quality, Safety and Accreditation.
This promises to be a reflective and meaningful discussion, one that goes beyond system into values.
Hello, good afternoon. Can we all settle down, please? So let me start this session. And on this session, there is no debate. There is no debate on trust. If trust wasn't there, we wouldn't exist. And I think I must really compliment CAHO for putting these three words. You heard the words here. Tech, touch and trust. I think they just made the order wrong because they put it in alphabetical terms. I think it is trust first, touch next. And for supporting all that, we need tech. Tech doesn't build trust, it only supports it. I think this is a very important topic. This is a big elephant in the room. This is the first ever conference on healthcare I've attended where trust is being discussed in the big panel. It is a big elephant for our sector, and I think it is really good that CAHO has brought this up. I think we should take it up very seriously, and we have to take it up very respectfully and very honestly. So, patients' expectations, we know they want to have safe care, we know they want to be witness, they want to go back home safe, they want transparency, respect. I think those are kind of given, because that is not what trust is, because that is the normal expectation. Slide there, please. But the healthcare industry works very hard to deliver in all those areas. But patients judge us and feel that they can trust us by what they feel on the bedside, what they feel at the billing counter and on the complaint desk. So I just wanted to, I got just two slides to set the context. I think compliance is what we keep talking about. We had a big discussion on CAPA. That's on the left-hand side here. CAPA is mandatory. All the stuff on the left side is mandatory because somebody tells you to do it. But what is on the right side is really what governance is all about, which is honest communication, fair, transparent billing, timely grievance, ethical. I'm not sure you can read the last line there. It says, if you do the right ones, it becomes a differentiator. And I think the healthcare does need a differentiator. So, is trust really broken? And I think there is a slide here. There are many, many players. There is an insurer, there is a doctor, there is a hospital, there is a pharma company, government, judiciary, parliament. For every one of them, you can see there are 2 or 3 points which say why the trust is broken. And I think the only people who can make that trust is us here. And I think that's what we're going to discuss here. So I'm going to take you through some questions here on, rather than have you all speak. So if that's all right, I will thank you for being here. Right, you're bringing an international perspective. Thank you for being here. Right, I think all this discussion is fundamental, not only getting accreditation, but this is beyond. And Dr. Kapoor, you have established so many hospitals. So let me start first. In your opinion, what is it that is one thing that patients look which can build trust?
Thank you, Mr. Mittal. Well, healthcare is very complex, and the only thing that patient wants today, everything revolves around the cost. See, transparency is something which we have to deliver to the patient. What the patient wants, they want that as soon as he comes to the hospital, immediate care, number one. Number two, structured care of what he wants. Number three, a predicted result at a predicted cost. Now those things can never match. No hospital can do it. You see, every hospital has an SICU, ICU, NICU, and every hospital employs all kinds of doctors. We have BMS doctors, MBBS doctors, intensivists also. So cost can never be the same. Patient wants a treatment at a predicted cost the way he wants it. Now that is the biggest gap. Now this can only be bridged by the insurance companies where the out-of-pocket expenses, the patient does not have to pay anything, then he will not bother for the, no complaints.
Thank you. Carsten, you've got many parameters for various ways of accrediting hospital. How can a soft issue, so-called soft issue of trust get built in to what you do?
Well, how is trust generated? Some people talk about the trust triangle: logic, authenticity, and empathy. Logic, I know you have the competencies and skills to do what you do. I trust your reasoning and judgment. Authenticity, I experience the real you. You are what you pretend to be. And empathy, I believe that you care about me and my success and you try to understand my problem and help me solve it. And what could we look for to ensure ourselves that this is the case in a hospital? Accreditation can of course be part of the solution. With all the limitations that we have heard about in the earlier discussions, accreditation is still a sign that you have basic processes and systems in place, but from an accreditor's perspective, I also think that we should move in a direction where accreditation looks not only at whether these systems are in place, but also how performance is within these systems, not by, let's say, supervising performance of hospitals, but perhaps adding an investigation of how does the hospital continuously assess its performance and correct it. Authenticity is of course much about transparency. You need to be transparent, as you should have said in one of those slides. And empathy, I believe you care about my success. Well, you experience this when you meet your hospitals, but there are metrics that can be used. There are patient-related outcome measures, grants that can be collected. And if a hospital collects and publishes prem results, well, that shows transparency, but it also gives you an opportunity to assess the strengths and weaknesses of that particular hospital. You can, of course, look at specific websites where patients can give feedback. Those exist in some countries. You look for Trustpilot, but I would say to you, don't look too much at what the complaint is, but take a very good look at how the hospital responds to it. Do they acknowledge the experience of the patients? Do they honestly try to mitigate, and do they honestly try to learn? If this is apparent, that I would count as a good sign.
Thank you. So, trust is not this fuzzy, soft touch, right, which is what people feel. Everything that we spoke about, process, procedure is real. But trust is not the soft thing. It really impacts safety because people delay their decisions because they don't trust. They come late for representation to the hospital, so it actually affects. When you look at it from, both of you can attempt this, when you look at it both from the country that you live in and also from your own visibility, what do you think, Dr. Sodzi, you think is your view on where patients see the gap?
Well, the fact of the matter is that
Can you keep it close?
a number of patients, you can hear me? Yes, a number of patients coming to the interaction already given a high level of trust to health professionals. And so it's a question of how you maintain that trust and prevent it from being broken. And often it's very simple. It's a question of how much improved communication you maintain with the patient. The time that you give to listening to the complaints, giving them the sense that you are paying due attention to what they're saying and not just scribbling it off. As we heard from the former Vice President, sometimes by the time the patients finish talking about their complaints, you've already diagnosed, you've already written the treatment, and all of these things breach trust. The other one also has to do with an area that sometimes we don't speak about often, and that has to do with fleecing of patients financially. You know, corrupt activities that go on in healthcare settings. So there have been instances where a patient is terminally ill, you know that there's not much you can do apart from palliative care, and yet you prescribe the most expensive medicines, you promise things that you cannot deliver. These things go a long way to breach trust. Or where we have insurance systems that have been put in place to make accommodation for the cost of care, and yet you cause patients to also pay a little bit of the cost of treatment. These things all breach trust. And then when substandard medications get used in a process of care and patients return after spending an inordinate amount of money, these things breach trust. So it's about designing the system in such a way that you can be upfront in your communication, you can diagnose and treat, and then you can maintain the communication so that the patient is part of the process of care.
Thank you.
Yes.
Can we keep it brief? I've got a number of questions, so if we can keep it just a couple of minutes.
Okay. Yeah, so I also think that the institutions, either of state, can also ensure that trust is sufficiently maintained. One has to do with, for instance, the policy people, especially the Ministry of Health, and how they are able to ensure that the architecture of healthcare in the country is provided as it should be. The other is the regulatory bodies. I mean, in a lot of the countries, especially in the continent where I come from, and I've learned also in other continents, there are instances of regulatory bias. I mean, trust is not only, I don't think it's only about the patient, but there are also, if we talk about the customers as far as the healthcare is concerned, the providers, the hospitals, etc. are also recipients or are also customers. So sometimes there would be a breach of trust as far as their relationship and interaction with the sector is concerned. For instance, when there are regulatory breaches, and then sometimes we are very hard on public facilities, we are very hard on private facilities, but very soft on public facilities. That can be a breach of trust, and where patients are making choices and decisions as far as healthcare is concerned, it can influence them and what they do. Yeah.
So thank you. I think you raised a very important point, saying you use the word fleecing, right? And I think cost, and I think that's where. So I think let's now focus on real issues like processes and so on. You can only go that far, but there is a trust which is broken because I, as a patient, feel that my pricing is not fair. So, Dr. Kapoor, we have now more and more precise diagnosis. We have robotic surgeries. The doctor has more tools to do a better diagnosis, and all this will cost. But who is going to be telling the patient? AHPI, CAHO, ISQua, who will educate the patient that if their care has to be better, which it has become from the past, it will cost money.
Well, still I would say that in our country the health.
Can you keep quiet in the back, please? Can you please stop talking there? Excuse me? Can you please? Thank you.
Excuse me, actually, I would still say that the healthcare in our country is the cheapest in the world, even today. The problem is that patients are unable to understand why a certain cost is high or certain cost is low. Based on the capex of a hospital, or a robotic surgery, or a lab surgery, the cost will be entirely different. What we should do is see, the patient would believe the clinician more than the hospital. So the clinician has a role where he bridges this gap between the hospital trust and the patient and tell him that why, it's not the question that how much it will cost. Idea is that why it is costly. So that gap has to be bridged by everybody, including our accreditation agencies, HPI or CAHO, as well as the government. The government and the insurance companies have to come forward so that government has to tell the biggest standard platform where they will say that the outcomes will depend on the cost and the cost will depend on the outcome. So this gap has to be bridged. Again, the government has to play a big role to let people know that this quality will cost this much and this quality will cost less.
So we have Dr. Agarwal, Joseph, we have HPI, Ganiji here. Sir, the question is, who will take the burden of educating patient community in general that it is becoming more precise, it is going to get more expensive, but reasonable at the same time. And I think that's a need, and you can look at it, and many times people like RPI or the associations of pharma, many associations are actually conveying that point. So I hope there is a takeaway from this discussion that we have a role to play to build trust across. So thank you very much for those inputs. This is the topic that's bothering, right? I live in Delhi and I get a lot of calls saying, who is the best doctor for cardiology? Who is the best doctor for orthopedic and so on? And we have some great doctors. Should patients trust the hospital because of the process they have, and obviously we believe they have good doctors, or patients should go after a doctor because he's a celebrity doctor?
So the concept of a celebrity doctor is very interesting, and I don't think we should be dismissive. You know, we've come from systems where we didn't have social media, and so people would rely on just the hospitals. But now some of these so-called celebrity doctors have millions, and sometimes billions of people following them on social media. So I think we do need to take account of that. And if they are qualified, and if they are sharing appropriate information in line with professional ethics and standards, I don't think there's any problem with that. Rather, the hospitals must look at what the Lancet Global Commission, for example, spoke about as redesigning the process of care. Many people have conditions that will prevent ill health before they even fall sick and come to hospitals. So the question to the hospitals is, how can you position yourself in such a way that you engage with the patients even before they fall sick, build trust and relationships so that by the time they come to you, they already know you. And then within the hospital setting itself, how can you involve patients in the care? Some people have made patients part of their patient and family advisory councils. Some people have health promotion units that engage actively with the public. So it's not about saying that the so-called celebrity doctors are bringing more attention to themselves, but working in collaboration to be able to get the outcomes of need.
So there's a lot of discussion that goes on that because so many new hospitals are coming up, and obviously senior doctors are scarce, so we have to compensate them very well, and I think hospitals have to financially survive, right? And hence I think this whole issue that comes up. Dr. Carsten, we did a small survey and we asked patients how to choose a hospital. Actually, they did not know about accreditation, right? Which is a great work. It is required, I think. If accreditation happens, hospitals are good, their processes are good, quality is assured in a lot of ways. Who will take the burden of educating patients so that they trust much more a hospital because it's accredited? Till I got involved in the patient safety, we didn't know about accreditation. People don't know about accredited labs. Who is responsible for letting patients?
Well, first, and I would say we had the same experience in my country. Patients knew very little about accreditation. First, you could ask yourself, is it necessary for patients to know about accreditation? Accreditation is a tool the hospital uses to improve its performance, and what's important to the patient is the performance, not the tool by which it achieves it. But of course, there is a role for everyone, for the accreditors, for the hospitals, but we both have vested interest in claiming that accreditation has something to say, and it could be useful if organizations like yours, for instance, made up their mind. If you believe accreditation to be an important parameter for patients when they choose for the hospitals, maybe you would be the trusted one to tell them, yes, we have no interest in that, and we believe that this is what you should look at.
So anyway, Dr. Carsten, I still hope that this is promoted, because when I look at advertisements of hospitals, this is the only way I judge. They have robotic surgery, they have everything that we talk about, and he has to take a decision. I would take a decision based on the fact that some international agency is accredited. So that would be my expectation.
Yeah.
So there are, I need to just ask a follow-up question here. So I, as a patient, and we're talking only about patients and what they expect, I see the doctor and I see the nurse, right? What is the role of executive management, the senior management? They, of course, many of them are practitioners, but today we have non-practicing CEOs and so on who manage. What do you think is their role to build trust after that?
I think they play a very crucial role, especially as far as accountability is concerned. They are supposed to ensure that the system and the providers are accountable. Wherever there are complaints of breaches of trust, they should be able to identify and then apply the rules where necessary. Yeah, so that is where the patient can trust the system, trust the process of care, and then trust the outcome of care. That where chief executives, where top executives and leadership are accountable and ensure that the accountability systems and processes are in place, they will be free to interact with the healthcare providers as much as possible. And all of these issues of fleecing and other negative conduct, I am sure, can be nipped in the bud. Thank you.
See, we have to, first of all, bridge the gap. By gap, I mean that we have to have more quality beds in the country. What is happening today, there is consolidation. One hospital is buying another 1,000 beds from some other hospital, and they are buying another 1,000 beds from some other hospital because of equity funding. So we have to create quality beds to bridge the gap so that everybody is able to get the similar kind of treatment. The difference will go away. Secondly, for the management, I always believe, see, I am a doctor myself, and it's a doctor in a hospital. I believe that it's the doctors and the clinicians who should be doing the best treatment, and the management should enable it for them to deliver. So the trust is more with the doctor, less with the hospital, always. And this will always remain. But from the management, see, ethics and transparency should be totally non-negotiable. This is what I feel.
So this morning we had Dr. Shaikula, who actually spoke about values and so on, and he did say that his one point. The hospital was ethical. Right? And then there are many chief executives who actually do management by wandering around. When they actually go and use the same toilet that a patient uses, they actually go to the OPD. They go and see what the waiting line is. The moment the chief executive is seen there, the rest of the organization works. They eat the same food that is offered in the canteen to the staff, and I think the level goes up. So there are a lot of ways that I think chief executives could play a role. And we have here very senior people. Dr. Thopel himself has actually led many such initiatives. Sir, he's called the lead man, as you know, in eliminated land lead. We have issues on mercury that got eliminated. So there are a lot of things that we have collectively done. But I hope that this message of trust is taken very seriously, because at this point the trust levels are so low, I can tell you. We went to insurance companies and they were very impressed. They said, look, if you give us all your material, we will help you. That will help us reduce our claims. So we said, okay, how will you help us? They said, no, first, please help us with the hospitals, because we are always at loggerheads with them on billing and so on and so forth. So I think there is a need for us. The issue of the need is beyond patients, because the question, and again this is to the panel, is if we do not act, somebody else would. At this point in this country, there is right now a debate going on, and Dr. Gyani, you had raised this issue this morning of the difference between the insurance companies and the healthcare providers, but it will keep coming up. So we do not want this to be regulated. I think there is self-regulation that the industry should come up. Do you have a view on self-regulation?
Well, the role of a regulator or an accreditor cannot be to inspect and supervise everything. It is a good system of self-regulation and self-monitoring is imperative if we are to achieve any good results and any good outcomes of the activities of our healthcare provider. And perhaps the role of accreditation could be seen more like overviewing your own system. How do you monitor your own performance, your own problems yourself? Can you demonstrate that you know what your performance is and you have taken corrective actions when there were issues, rather than trying to overview and supervise every processes? The moral picture would be in kind of an evaluation machine where we think that by requiring people to document everything and controlling the documentation to secure that everything was in compliance with the prescriptions, that would be a nightmare. And that's not what we want to achieve.
Dr. Elom, what do you think shall be done to reduce the trust deficit in a hospital? Trust deficit.
Okay, yeah. So I think one is on regulation, external regulation. Two should be self-regulation amongst practitioners. I think three, I will recommend that health facilities should implement so there are 6 dimensions of quality, but I like the extended, which is the 8 dimensions, and it adds 2, which is integrity. And I think integrity is key, that health facilities should ensure that there is integrity, one that is seriously implemented amongst practitioners, seriously upheld amongst practitioners, and then the other dimensions of quality should also be robustly implemented. I think that can restore trust to a large extent.
Thank you. Since you are looking after vaccination, in the work we do, we approach patients for 2 things. We gave them that adults should get vaccinated, and the second is we gave them a list of cancer tracers, right? Because cancer, if detected early, can solve. And when we did the research, we actually were told by the healthcare community, right, that these 3 or 4 are proven vaccines. These 2 or 3 or 4 are real cancer tracers. Others are actually a lot of marketing by pharma companies, right? So since you are looking after vaccination, That you do, right? Yeah, sorry. How do you get over these kind of trust issues?
So it's interesting that you should wade into vaccine, manufacturing, because Ghana is at a very early stage of that. And we've gotten to a very interesting phase where the question is, do you discuss the issue purely as a technical manufacturing issue, or do you build trusting relationships with their communities? And we have realized that it is not simply a manufacturing question. So the Ghana Vaccine Institute, for example, has started a national perception survey, and we are taking people's views on how they would trust the vaccines that are going to be manufactured. And there are issues coming up about regulatory compliance, compliance with quality and safety standards, taking guidance from the Food and Drugs Authority, the WHO, and we believe that when we factor these things in, not just after the manufacturing of the vaccines, but as part of the manufacturing process, would engender the trust right from the get-go. And these are ways in which we are doing it. So being transparent with the processes, being upfront with the communication, and involving them in the process, I think these are ways in which we're engendering trust in the vaccine ecosystem in Ghana.
So, I'm getting to the end because I think we were running late as well. I have two last questions. And I'm bringing you an Indian situation. I think we discussed that there is need for capital because it's a very capital-intensive industry. It's brick and mortar, it's equipment, it's really beds that cost a lot of money, everything. So it's good that we have now private money coming in. How do you balance financial viability and ethics? Are they in conflict? Because I have to ensure that I make money, at the same time I make money ethically.
See, actually, it is at the crossroads. So money comes, you expand. And the money which comes, they want a certain IRR. Obviously, they want some IRR. So at times you are, compelled to basically come up to those levels. That may add some cost for the patient. But on the consequent side, it is helping in basically having quality beds in the country, which would not have been possible otherwise. And if the company or the CEO of the company or the MD of the company or the head of the company has some ethics and some transparency is there, I'm sure that both can be matched very well. It all depends on your thought. And again, if you are emotively attached with your company or attached with your hospitals, I'm sure that this thing will not happen. The problem arises when there are people who do not belong to the hierarchy of the hospital. They take up a job for 2-3 years, and they go away, they create numbers. We don't want to create numbers, we want to create patients.
Thank you. So, I've been getting this buzzer. Dr. Topoli, want to say something? I'll just give you a sentence, sir. I think one thing is coming out very clearly. This CAHO stands for patient safety and quality. And one very big ingredient that I think we have brought to the table, and I hope this is not the last time, this is not a conference issue. I think trust has been added into this part. There was compliance and governance, which I think is very different. But I hope that in every single conference of healthcare, trust should be a big topic, a very major ingredient that will have to be addressed. I think this is the big takeaway. I have to give 1 minute to Dr. Thupil here. I'll get the mic from him.
I need all your attention, please. I am not attending this as a representative of healthcare organizations. I am attending this representing the patients. As a patient, I have 3 things when I come to hospital, to a clinician. Number 1, my safety. Number 2, my comfort. Can you assure me my safety and my comfort? Number 3, my rights. What are my rights? Can you tell me my rights? These are the 3 things I expect when I come to a healthcare organization. Then only I feel comfortable. Not only that I come, I will recommend everybody to come to the organization. This is the trust. When there is a trust between the patient and the hospital or healthcare organization, there will be a quality automatically installed. When I come for a major procedure in a super specialty hospital, you know how many people are responsible? Minimum 183 people. Are they aware of that? Have we prepared our hospital people that you are responsible for this patient's care? Is that in system established, understood? Only then, what do patients expect? This is what I expect from hospital governance today. It's not just the top level management. It's not just the security or the housekeeping staff. Everybody. This is today's organizational accountability.
Thank you. So, I think the time is up, but I think you wanted to say something. I just say complete this sentence. If there is one thing that you have to do to enhance trust and patient expectation on governance, what would you do? Yes. Just one, very briefly.
I still believe that transparency of treatment at a cost which is paid to the patient, plus ethics. Three things will always make a trust.
Okay, now.
Yeah, I think if there is one thing, it will be imbibing in practitioners that we should love. And that was the last commandment of Donabedian before he died, that thou shalt love. And I am sure if we are able to love our patients as Donabedian recommended, I am sure we are going to be transparent with them. I am sure we are going to be open to them. I am sure we are going to ensure that the environment that is created is trustworthy, that they will be confident in us and they will be confident in the care that we provide them. Thank you.
So for me, it will be a quotation from Don Berwick, a mentor of mine. He says that the patients are looking for three things. He says, help me, which is clinical effectiveness, do not harm me, which is safety, and be nice to me, which is patient experience. So as long as we are paying attention to these three things, the patients will build the trust that we want.
Well, it's difficult to add anything to this, but I would say again that the three things that can from time to time be missing would be safety, it would be honesty, and it would be empathy, the feeling that they really care for you.
So on that note, thank you very much, panel. I appreciate your time here, but this was a very important topic, and I hope this will continue as not only as a debate, but we'll all act on it. Thank you so much.
Thank you so much. If trust is the foundation, then what comes next is perhaps the ultimate test. Can we sustain it?
Because in healthcare, doing the right thing is essential, but doing it sustainably is a real challenge.
I have a quick announcement. The delegate kits are available and can be collected from stall number A113.